Welcome to another episode from the Veterinary Medicine Digest. Today we are embarking on a high-level exploration of the shifting landscape of neuroinflammatory diagnostics, specifically focusing on the emerging role of redox markers and enzymatic activity within the central nervous system of our canine patients. For the veterinary neurologist, the challenge of distinguishing between various non-infectious inflammatory conditions has long been a hurdle that requires a delicate balance of clinical intuition, advanced imaging, and traditional laboratory analysis. While our standard tools have served us well, the quest for more specific, minimally invasive biomarkers is driving a new era of research that promises to refine our diagnostic accuracy and prognostic capabilities. At the center of our discussion today is a pivotal study titled Analysis of Paraoxonase-1 Activity and Cupric Reducing Antioxidant Capacity in Cerebrospinal Fluid of Dogs with Neurological Disorders, which provides a fascinating look into how we might use the internal environment of the brain to better understand disease states. To appreciate the significance of this new research, we must first establish the clinical context in which these biomarkers are being investigated. Non-infectious inflammatory central nervous system disorders are a major cause of severe and potentially life-threatening neurological disease in dogs. These conditions are generally categorized into two primary groups: steroid-responsive meningitis-arteritis, which primarily targets the meninges and associated vasculature, and the meningoencephalitis of unknown origin, which involve the brain parenchyma itself. Meningoencephalitis of unknown origin is an umbrella term for a group of idiopathic inflammatory diseases that include granulomatous meningoencephalitis, necrotizing meningoencephalitis, and necrotizing locoencephalitis. Despite decades of research, the exact underlying causes of these conditions remain elusive, though they are widely presumed to stem from an immune system dysregulation or an autoimmune process. This theory is bolstered by the fact that many of these patients show a positive clinical response to immunosuppressive therapy, particularly high-dose corticosteroids. In the current clinical standard, a presumptive diagnosis of these conditions relies on a combination of signalment, clinical presentation, advanced diagnostic imaging, and cerebrospinal fluid analysis. However, a definitive diagnosis for many of these conditions, especially the subtypes of meningoencephalitis of unknown origin, essentially rely on postmortem histological evaluation. This diagnostic gap is precisely why the identification of ante-mortem biomarkers is so critical. We are looking for indicators of normal biological processes, pathogenic processes, or responses to intervention that can be measured reliably. In the realm of neuroinflammation, researchers have explored everything from acute phase proteins and antibodies to cytokines and genetic markers. Steroid-responsive meningitis-arteritis is perhaps the most well-characterized in terms of systemic markers. It is unique among these conditions because it typically manifests with a systemic inflammatory response, including pyrexia and a significant inflammatory locogram. This systemic involvement allows for the detection of acute phase proteins like C-reactive protein and serum amyloid A in the peripheral blood. These proteins are highly sensitive indicators of systemic inflammation, changing in concentration by at least 25% in response to pro-inflammatory cytokines. In dogs with steroid-responsive meningitis-arteritis, C-reactive protein is markedly increased in both serum and cerebrospinal fluid. However, these markers often lack the specificity to differentiate this condition from other systemic inflammatory states like sepsis. Furthermore, in the meningoencephalitis of unknown origin, these systemic markers are often frustratingly normal, reflecting the more localized nature of the inflammation within the central nervous system. Cerebrospinal fluid analysis remains the cornerstone of our diagnostic workup, typically showing elevated protein concentrations and mononuclear pleocytosis in cases of meningoencephalitis of unknown origin. The specific cell types found can sometimes hint at the underlying pathology. For instance, necrotizing encephalitis are often dominated by lymphocytes, while granulomatous meningoencephalitis may show a more mixed cell population. Yet, up to 22% of dogs with these conditions can have completely normal cerebrospinal fluid analysis. This brings us to the necessity of looking deeper into the biochemical and molecular signatures present in this fluid. One area of intense interest is the role of oxidative stress in the progression of neurological damage. In human medicine, it is well established that oxidative injury, primarily driven by the respiratory burst of invading macrophages and resident astrocytes, plays a central role in the pathogenesis of diseases like multiple sclerosis, Alzheimer's disease, and Parkinson's disease. This process involves the generation of reactive oxygen species that impair mitochondrial function and lead to a cycle of inflammation, demyelination, and axonal damage. It stands to reason that similar mechanisms are at play in canine neuroinflammation. This brings us to the main focus of our deep dive, the study by Velasco-Martinez and colleagues. They investigated two specific markers in the cerebrospinal fluid of dogs with various neurological disorders, paraoxonase-1 activity and total antioxidant capacity, as estimated by the Kuprick reducing antioxidant capacity method. Paraoxonase-1 is a particularly intriguing enzyme. It is synthesized primarily in the liver and circulates in the blood bound to high-density lipoproteins. Its primary role is to protect these lipoproteins as well as low-density lipoproteins from oxidative damage by hydrolyzing lipid hydroperoxide. Interestingly, it also functions as a negative acute phase protein, meaning its levels typically decrease during periods of systemic inflammation. In human medicine, decreased serum activity of paraoxonase-1 has been linked to several neurodegenerative and vascular diseases. A landmark human study by Castellazzi and others found that serum arylesterase activity, a component of the paraoxonase-1 enzyme, was significantly lower in patients with multiple sclerosis, Alzheimer's disease, and vascular dementia compared to healthy controls. They suggested that depressed arylesterase activity could be a common denominator of different neurological diseases characterized by an altered systemic redox balance. However, when they looked at the cerebrospinal fluid of multiple sclerosis patients, they found that while arylesterase was detectable, its levels did not significantly differ from other neurological control groups. The canine study by Velasco-Martinez and colleagues took this a step further by comparing these markers across several distinct groups dogs with idiopathic epilepsy, intracranial tumors, various inflammatory pathologies including meningoencephalitis of unknown origin, and steroid-responsive meningitis-arteritis, and both acute and chronic intervertebral disc herniations. Because of the ethical concerns regarding the collection of cerebrospinal fluid from completely healthy dogs, the idiopathic epilepsy group was used as a control, as these dogs typically have unremarkable imaging and fluid analysis. The findings of this study provide a striking contrast to the human data. They found that paraoxonase-1 activity was significantly higher in the inflammatory group compared to the dogs with idiopathic epilepsy, intracranial tumors, or acute intervertebral disc herniation. This is a fascinating result for the neurologist to parse. While human neurodegenerative diseases show a decrease in this activity, the acute or subacute inflammation seen in canine patients seems to trigger a different response. The authors suggest that this elevation could represent a compensatory antioxidant mechanism, where the brain locally increases paraoxonase-1 production or allows for increased influx due to altered blood-brain barrier permeability in response to intense oxidative stress. This relationship between inflammation and paraoxonase-1 was further highlighted when they analyzed the samples based on cell counts. The study found that paraoxonase-1 activity was significantly higher in samples with pleocytosis compared to those with normal cell counts. This suggests that the presence of inflammatory cells within the central nervous system is directly linked to the upregulation of this protective enzyme. Interestingly, while the presence of pleocytosis was a predictor of higher enzyme activity, the actual magnitude of the white blood cell count did not correlate with the level of activity. This implies that once a certain inflammatory threshold is reached, the antioxidant response is activated, but it may not be a simple linear relationship. In contrast to the paraoxonase findings, the total antioxidant capacity measured by the Kuprick reducing antioxidant capacity method did not show significant differences between any of the groups. This highlights the complexity of the redox balance. Total antioxidant capacity is a broad measure of both enzymatic and non-enzymatic antioxidants, and it is possible that in these acute disease states, the consumption of some antioxidants is balanced by the adaptive increase of others, resulting in a stable overall reading. This makes specific markers like paraoxonase-1 much more valuable for the clinician looking for targeted insights into the disease process. To further contextualize these findings, we can look at the work of Horvatich and others, who used a multi-omics approach to study cerebrospinal cerebrospinal fluid changes in dogs with intervertebral disc herniation. Their research utilized high-resolution liquid chromatography-mass spectrometry to identify over 200 proteins that were significantly changed in dogs with disc herniation. Among the top upregulated proteins in their intervertebral disc herniation group was paraoxonase-1. This aligns with the Velasco-Martinez study and suggests that even in non-primary inflammatory conditions like disc herniation, the resulting spinal cord compression and secondary injury cascades involve a significant oxidative stress component that triggers a paraoxonase response. The secondary injury following a mechanical insult like disc herniation is a complex biochemical cascade involving vascular dysregulation, excitotoxicity, and an inflammatory response. The multi-omics model identified several key features involved in these processes, including proteins related to neuropathic pain and inflammatory response such as follistatin-like 1 and secretogonin 5. The fact that paraoxonase-1 is consistently identified across these different models of central nervous system injury underscores its potential as a broad but important marker of neurological health and resilience. Another crucial piece of the puzzle is the integrity of the blood-brain barrier. Research by Haniel and colleagues used advanced magnetic resonance imaging techniques, specifically dynamic contrast enhancement and subtraction enhancement analysis, to quantify barrier dysfunction in dogs with meningoencephalitis of unknown origin. They found that dogs with identifiable barrier dysfunction had a significantly higher prevalence of seizures. Furthermore, they demonstrated through immunofluorescent staining that these areas of barrier leakage were characterized by the extravasation of albumin and the activation of microglia and reactive astrocytes. This extravasation of albumin is particularly significant because it is known to initiate inflammatory signaling pathways, specifically the transforming growth factor beta pathway, which can lead to further astrocytic transformation and the development of epilepsy. This connects back to our biomarker discussion, as albumin is often used to validate proteomic findings and is a known indicator of barrier disruption. If paraoxonase-1 is entering the central nervous system through these same leaks, its presence in the cerebrospinal fluid is not just a sign of inflammation, but a direct reflection of the severity of the barrier breakdown. The clinical utility of these markers also extends to prognosis and the evaluation of treatment response. For instance, in dogs with steroid-responsive meningitis-arteritis, C-reactive protein and serum amyloid A have been shown to follow the clinical course of the disease, decreasing with remission and increasing again during a relapse. In the study of spinal cord injury and disc herniation, haptoglobin has emerged as a significant marker. Anderson and others found that haptoglobin was significantly higher in the cerebrospinal fluid of dogs with severe spinal cord injury compared to those with mild or moderate injury. Like paraoxonase, haptoglobin has neuroprotective properties, specifically through the binding of free hemoglobin and the suppression of lymphocyte function. Interestingly, in a pilot study by Bitterman and others, it was found that dogs with higher cerebrospinal fluid ferritin concentrations following intervertebral disc extrusion actually had better outcomes. Ferritin is the primary extracellular iron transporter and is synthesized by macrophages to bind free iron and prevent the formation of tissue-damaging free radicals. This paradoxical finding suggests that a robust antioxidant and iron detoxification response is a key factor in recovery from neurological injury. This reinforces the idea that we should not just be looking for markers of damage, but also markers of the body's protective response. As we integrate all this information, a clearer picture emerges for the veterinary neurologist. We are moving away from seeing these diseases as simple inflammatory events and toward a more nuanced understanding of the interplay between immune activation, oxidative stress, and the protective biochemical defenses of the brain. The study by Velasco-Martinez and colleagues provides a foundational step in identifying paraoxonase-1 as a potentially powerful tool in this new diagnostic toolkit. By measuring this enzyme in the cerebrospinal fluid, we are gaining a direct window into the oxidative status of the central nervous system, which routine cell counts and protein measurements simply cannot provide. However, as with all emerging research, there are limitations and many unanswered questions. The sample sizes in these studies are often small, which is an inherent challenge in specialized veterinary medicine. The inflammatory group in the paraoxonase study was heterogeneous, combining various conditions that might have subtly different biochemical signatures. We also need longitudinal studies to determine how these markers change over time and in response to different therapeutic protocols. For the clinician, the immediate value of this research is the inspiration to look beyond the standard laboratory report. When we see a patient with suspected neuroinflammation, we must consider the underlying oxidative storm and the barrier dysfunction that is likely occurring. The future of veterinary neurology will likely involve the use of diagnostic kits that can rapidly assess a panel of these biomarkers, allowing for truly personalized treatment plans. Imagine being able to monitor a dog with meningoencephalitis of unknown origin, not just by their clinical signs, but by the precise fluctuations of their antioxidant enzymes, adjusting immunosuppressive doses in real time to match the internal environment of the brain. This level of precision would be a transformative leap forward in our ability to manage these complex and often frustrating cases. In conclusion, the investigation into paraoxonase-1 activity and other redox markers in the canine central nervous system is a testament to the sophistication of modern veterinary research. By bridging the gap between human medical insights and our unique canine patients, we are uncovering new ways to detect, understand, and eventually defeat neuroinflammatory disease. As we continue to refine these markers, we move closer to a day when a definitive antemortem diagnosis is the norm, and our prognostic predictions are based on the solid foundation of molecular reality. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.